Hello everyone. Today we would like to talk about iliotibial syndrome or iliotibial tract. Iliotibial approximately split into superficial and deep layer enclosing tensor fascia latae muscle anchoring to iliac spine between sartorius and gluteus medius, descend transverse to vastus lateralis, insert to girdous tubercle of the tibia. Other attachment point is lateral epicondyle of femur and patella retinacula, which limit patella transition medially. Action of this muscle is stabilize hip and knee joint, and from 0 to 30 degree it does knee extension, below 30 degree do the knee flexion. Why someone has pain, other do not have pain. Iliotibial syndrome is an overuse injury. Mostly occurs in a runner, cyclist, hockey, football player, tennis player, any other running related activity. What are the predisposing factors for the injury? Modifiable factors are running on uneven surface, running uphill, or poor shoes, poor running technique. Anatomical predisposition are uneven ilium. Ilium could be anteriorized or posteriorized, which can cause uneven knee. Weakness of abductor or adductor can cause knee unalignment. As we go down, the foot deformities such as pes planus, pes cavus, flat foot or high arch also can cause knee unalignment. From coronal plane, when you look, some patient has a pronating foot, which can cause knee varius or valgus. The knee goes in or out, which can cause pressure on the knee and pressure on iliotibial band, which leading to pain. Iliotibial band can clinically diagnosed and rarely need further imaging modalities. Clinical presentation: patient will present pain distally lateral knee, will be burning pain, stiffness when the knee is from flexion to extension will cause more pain. Test for iliotibial band syndrome, Nobel test, when knee is from 90 degree to extension, it will cause pain. The other test is Ober test, when the patient is sideline position. You hold the patient knee gradually you let the knee, if the knee attached to the other knee is positive test. What happens if you have injury? During acute injury, you need to rest, compression, ice every 3-4 hours from between 10 to 20 minute frequency, strengthening of the abductor muscle. As we say, weakness of adductor can cause knee pressure and knee from iliotibial pressure producing pain. There are 3 theories suggesting that causing knee pain. One is friction, overuse, repetitive flexion extension causing pressure on the between the iliotibial and lateral epicondyle, causing friction and pain. The second theory is adipose tissue compression during flexion extension, because adipose tissue, which is known as fatty, is highly vascularized and innervated by myelinate or non-myelinate nerve fibers. The last theory is lateral epicondyle bursa, which compression of tibia against the bursa produce inflammation. However, last research do not agree with bursitis and that there is a bursitis due to they believe fatty tissue, as is highly vascularized, compression of this fatty tissue producing inflammation and causing knee pain. When you have a knee pain, it's best to consult your practitioner. As we said, if the pain do not subside between 4 to 6 weeks or 8 weeks, it's better to consult your practitioner. The treatment modalities will be NSAID, non-steroid anti-inflammatory, myofascial release, breaking up adhesion in the tendon and the tissues, corticosteroid injection as treatment also is diagnostic. With the conservative treatment, when you do not get resolved, your practitioner most likely will refer for further imaging. MRI will be most accurate to rule out other other structure that causing knee pain. So what are the other structure? What are the differential diagnoses of the knee? The pain could be referred from the hip to the knee, lateral collateral ligament, lateral meniscus injury, hamstring, bicep femoris attached to the head of fibula, which is close to lateral condyle, popliteus muscle, tendon attachment close by. What can else we rule out? All causing knee pain. Yes, we should not forget one, patellofemoral tendinopathy, which is more linking to iliotibial syndrome. Surgery is rare for iliotibial syndrome. if severe case, if other any other treatment do not solve the injury, if it's severely deteriorate, then it will be surgical intervention that might release the tendon. Before we closing our video, one other action of the iliotibial band as attached to Girdler's tubercle, it's limit to knee internal rotation. In next video, we will do a knee examination and we will perform all clinical tests. Thank you very much for your time and watching this video. We will bring to our model more closely to show you iliotibial band. As you see, is dense tissue and very strong tendon, which is the most stabilizer of the knee and the hip. The most beneficial exercise will be strengthening abductor and adductor, and avoid repetitive uphill running if you have a pain. When you don't have a pain, then you can, after 6-8 weeks, when it's pain totally resolved, you can run uphill. Thank you very much again for your time, and see you in next video. I hope you like this video, so we can show you London by the night. It is local time 1 a.m. I have to wait to get quiet because lots of crowd around. Tower Bridge.